This is now recording, and I welcome everyone to the March First Friday. We've been doing this all year now as the kind of collaborative work of nurses with others or nurses with our own. And we sort of have both of that with our guest speaker because Dr. Joan Block has worked with our colleague and dean, Marcia Gardner, but she's also, what I thought was so important for us is that she chairs the interprofessional, but you called it interdisciplinary too, interdisciplinary committee that discusses economically disadvantaged populations and health inequities. And she also has a data science and an informatics background, so I can't wait to see some of that. So Dr. Block comes to us from Drexel University, where she's associate professor and director of global health initiatives, which again is another thing that whether or not my attendees are maternal child people, as some of us are, I think she has a lot to teach us about the ethical conundrums of conducting perinatal health disparities research. So I'm going to turn the screen over to you well, you should be able to share the screen at this point, just pulling it up.
Okay, there we go. Well, thank you. It's a real
Not yet. I don't see it yet.
You don't see it?
You know what? I probably, let me stop my screen.
Okay. Okay.
Oh, it's probably just behind it. Okay. Mine's in front of it. That's all. Hold on.
Okay, can you see
There
it
you
now?
go. There you go.
Okay.
You're in. You're in. Thank you.
Well, thank you. It's a real honor to be invited to Molloy College. I'm humbled by your warm invitation from Dr. Gardner, from Dr. Feig. Like both of you, I care deeply about families, family-centered nursing care, and both of you have contributed so much to this focus of nursing. So I hope my presentation does justice to your legacy. No. Oh, there we go.
There you go.
Okay, so I dedicate this presentation to my mother. I'm a child of Holocaust survivors. My mother, Sabina Rosen, was born February 2nd, 1927 in Krakow, Poland, and she died in Philadelphia, December 3rd, 2012. And I'm blessed, unlike her, to be able to hold my mother's hand on her last breath. Philadelphia gave her a life she never dreamed she would have, gave her freedom and 3 healthy daughters. As a teenager, I was obsessed with racism. I grew up during the Civil Rights Movement and also after World War II, as the world was trying to understand how could the Holocaust have happened. Growing up in Philadelphia, my father was very involved in the Holocaust organizations, and I would attend all the lectures I could. And actually, my first dean of, after I got my PhD, Dr. Susan Bakewell Sachs, it turned out her mother-in-law used to run these teaching programs about the Holocaust. And I heard a man, you know, when you listen to people with an accent, you have to really listen carefully so you understand. And I heard these words of a man talking about finding meaning and purpose in life. And I was trying to find what was I going to do with my life that would resonate, that would contribute to humanity. And through his words, I went to my library to search how I can study math and science, but yet give to others. I found nursing. I never knew a nurse in my life. And it turned out later that I found out that man was Viktor Frankl. That man led me to my journey as a nurse, where I could find meaning promoting safe motherhood to all, especially women vulnerable for poor outcomes. And my mother's words of wisdom continue to this day, be really important. Be nice, be as smart as you can, and even more importantly, always help others. So what's a more perfect fit? Nursing. So my presentation today, it's only going to take 10 hours, I promise, not any longer. Okay, anyway, my objectives are to describe how my practice-based clinical inquiry led me to this program of health disparities research. And I hope to translate through sharing some of the research that I've done, sharing concepts of social epidemiology as we study the social determinants of health that's guided by the life course theory. And throughout this, discuss some of the ethical conundrums of conducting safe motherhood research and health disparities research as a nurse. So why is this important? Well, I think I'm preaching to the choir, right? When we have such a strong capacity maternal child health nurses in this group, but every society has a vested interest in safe motherhood. Babies born today are tomorrow's future. We know the research is clear that healthy mothers are much more likely to have healthy babies. Healthy babies will grow up to be more likely to grow up to be healthy children, healthy adults. Communities that have more healthy adults are healthier communities. We also know that wealth and poverty influence maternal and infant health. Locally in our cities, New York, Philadelphia, Chicago, and globally around the world, and in cities around the world, where there's social inequities, there's health inequities. The richer countries become, the richer societies become, usually the more inequities there are between the rich and the poor, and the more health inequities there are. So my research questions stem from 40 years as a women's health nurse practitioner. They're not complicated questions, but the answers are very complicated. And even more complicated is to do something about what we know. Key questions are, why are birth outcomes among Black women worse than white women? I started asking this a long time ago. Many of us, back in the 80s, back in the 70s, we asked the same questions. But only now is our social awakening really addressing this in a way that I have great hope and optimism that we're going to start to see action in the next 10 years. I hope and pray. We know that there's higher rates of preterm birth among Black women compared to white women. We know that Black babies are more likely to die within that year after childbirth. And the differential in infant mortality between Black babies and white babies is due to the higher rates of preterm birth. We know that most babies born too early will survive, but many will not be able to grow up to be independent adults like all of us here. They may have lifelong sequelae. And with the NICU nurses, we know that reality. Why are maternal mortality and severe morbidity rates higher among Black women? What's driving this are also higher rates in cardiovascular disease and obesity among Black women. So my research training began in 1997, and I wanted to understand how research evaluates what was so important to me, caring for pregnant women. And there's a concept in research called utilization of prenatal care, and there's a very standardized ways to measure outcomes of prenatal care. So I had the ability to use existing data from a very, I guess, famous neonatal brain injury study. It was a cohort that followed babies that were born, low birth weight babies. They followed them. They continue to follow them. But instead of looking at low birth weight or normal birth weight or preterm or regular term deliveries, I wanted to look at an outcome that would be indicative of a poor life course outcome. That was before we really talked about life course. But I had in this data set, there was data on every baby that was born at 4 hours after birth if they had neonatal brain injury. Neonatal brain injury was defined as intracranial hemorrhage on a cranial ultrasound. What was interesting about this study is that at the time, the ultrasound was just introduced into practice. Prior to that, the babies in the NICU would have to be detached from their incubator and taken down to radiology to have a CAT scan. Well, when they introduced the ultrasound, in this particular study, the radiologists really didn't know what they were looking at because they didn't really know how to interpret ultrasound. So it was, from a research perspective, it was really a very clean, good study, and all the ultrasounds were done serially for research purposes, not for clinical purposes. So we had timed ultrasounds. Anyway, the key results of this study was that if the mother had no prenatal care, only if she was Black was her baby 2 times more likely to have evidence of brain injury as early as 4 hours after birth compared to white mothers. So this was all mothers that didn't have prenatal care. only if the white mothers didn't have prenatal care, there was no statistically significant association with neonatal brain injury. So this was actually interaction effect. This work led me to perinatal racial and ethnic health disparities. Now, does this slide look familiar, Dr. Gardner? Okay, so I use this slide a lot when I talk about this topic. This is from Dr. Gardner's study. These were the diagnoses amongst her sample. And did you have 8 mothers in your sample or 6? I always get confused.
This is my dissertation research.
Mhm.
8.
8. Of 8 mothers, these were primarily low-income urban mothers in Philadelphia. She found out from the mother's report that these were their diagnoses. Can you imagine how traumatic it is to be a brand new mother and to be told your baby had all these things wrong with them? As a nursing student, it was so traumatic for me to look at a baby in the NICU in this isolate. It was so traumatic, I couldn't imagine. I just thought, what if my mother had a baby that was born so sick? After all she went through, what if I would have a baby that was so sick? I actually, as a nursing student, as scared as I was always as a nursing student, I actually fainted in the NICU. Can you imagine how horrified I was? Anyway, with preterm birth rates, we know where mothers live matters. And this is well studied. The poorest countries have the highest rates of infant mortality, preterm birth. Preterm birth is a public health problem across the world. So you can see the poorest countries have the highest rates. And also in this country, there's variety where mothers live matters. In the South, the states in the South have the highest rates of preterm birth compared to others. Now in this slide, I like to explain this because it's beautiful social epidemiology. So from the social epidemiology literature, neighborhood effects of having a preterm birth infant differs from whites and blacks. And these graphs tell us that story. Can you tell why? I'll explain it. So look at the 2 graphs. The graphs on the top shows white mothers living in 8 different study areas. And as you, on the x-axis over here, tells the story about how deprived the neighborhoods are. So the social epidemiologists spent a lot of time taking different variables, rather than just say like a poor area versus a wealthier area. They took different variables on the census, from census data to create a neighborhood deprivation score. Because the more deprived the neighborhoods are, the more environmental stressors of those living in those neighborhoods. So and on the y-axis shows the likelihood of having a preterm birth. So just by glancing at these lines, you can see that the slope on the top graph is steeper than the slope on the bottom graph. And what this tells us for white mothers, as they go from living, and I'm going to use the term good and bad neighborhoods just for simplicity, but assigning neighborhoods as good or bad can really stigmatize neighborhoods. Redlining, if you know about that, we can talk about that afterwards. So I'm just using it for the sake of this presentation and to explain these slides. But we have to be very cautious when we go into neighborhoods and say, oh, this is a good neighborhood, this is a bad neighborhood. But so please excuse me for using that terminology, but for clarity. So as white mothers go from living in good neighborhoods to bad neighborhoods, their risk for preterm birth increases. And you can see that the slope of this line is steeper than on the bottom. What is this telling us? This tells us that for Black mothers, as they live in neighborhoods that are good, and we compare them to Black mothers living in neighborhoods that might have more deprivation, their risk of having a preterm birth doesn't change that dramatically. So it tells us that there's other things going on, which we know now. In this particular slide, a social epidemiologist are measuring the women's cumulative neighborhood deprivation exposure using longitudinal linked vital records, birth certificates, and to show life course risk for preterm birth on age, race, and neighborhood deprivation. Now, I sort of used the data and created this map to look at the 4 different lines here. The bottom 3 lines is what we always believed, those of us who are maternal child health nurses from the 70s and 80s, that there was a U-shaped curve. Oops. you can see on the left, in the very young women, the risk for preterm birth is higher. But then as women continue their childbearing years, or risk for preterm birth decreases somewhat. But then as they get older, it increases, that typical U-shaped curve. If we think about most of the evidence-based public health, maternal child health, public health programs, they're based on this curve. Primarily, lots of effort is put into the primiparous women who are first-time mothers. But look at this top line, this top black line. What these four lines are, on the bottom two, I told you look at the top, now I'm directing you to look at the bottom. But the bottom two lines show us white mothers living in, I'm going to say, better neighborhoods and worse neighborhoods. As white mothers live in more deprived neighborhoods, their risk for preterm birth increases, as you would expect. For Black mothers who live in better neighborhoods, less deprived neighborhoods, they have higher risk for preterm birth, which is consistent to the previous slide, but they have that U-shaped curve. That's a very different pattern than what we see in Black mothers that live in the most deprived neighborhoods, most environmental stress. They have their best reproductive outcomes in their younger years, and then the risk for preterm birth increases as they age. Now, if we were to design maternal child health programs geared to this group, it would probably look very different than what we have right now. That leads us to the construct that social epidemiologists have been using now for almost several decades, the weathering theory. It was named this by Arlen Geronimus in 1997, and since then it's been validated with good data. It's a leading theory that explains the preterm birth health inequities due to social inequities. And she explains that prolonged exposures to environmental insults due to social inequities and injustices deteriorate reproductive functionings across generations, resulting in poor outcomes for Black women in the United States. And of course, the history of slavery is critical to the environmental injustice and social injustice to these mothers. Allostatic load is also the term that's used in non-pregnant women. Weathering, the physiological effects of weathering, how it would play out or measured in pregnancy would be different than adults because of the immunological metabolic changes in pregnancy. But biologically, how could chronic and cumulative stress affect health? Well, we know the biology of stress, that there are physiological effects of stress with chronic stress that dysregulates the HPA axis that can cause damage to multiple organs and systems, making the woman, the mother in this case, suppressing the immune system, so she's more susceptible to have infection and inflammation due to that. And this plays out with COVID right now. We're seeing that repeatedly in our marginalized minority populations. This is a theoretical framework that we published to show how maternal psychosocial determinants of health adversely affects infant health outcomes. And so if you think about chronic and cumulative stress at the cellular level, it actually can cause hypoxia. There's three key areas that can cause hypoxia at the cellular level. I'm just showing the one domain of maternal and psychosocial stress. The other two during pregnancy is also metabolic disease, as well as nutritional deprivation. And if we look closer at the maternal psychosocial factors, you can see three different domains: women that have had traumatic experiences, women that that are exposed to excessive environmental stressors, and also individual temperament and coping. A protective effect is those that have an optimistic perspective on life compared to pessimistic. Those who are more prone to anxiety, depression, those who are more prone to seek coping mechanisms that may lead them to addictive behaviors to cope with the stress. So the life course theory, that's a popular term nowadays. It seems like it's a new theory, but it's actually not new. Its life course theory is also known as the life course perspective or the life course approach. And it refers to an approach that actually was developed in the 1960s for analyzing people's lives within the structural, social, and cultural contexts. So considering the life course theory, my clinical practice led me to this study that I'm going to share with you. Much of the health disparities research was looking at the Black and white differences. But what about the within group differences? At the time when I thought about the study, I was lucky enough to one day a week practice as a nurse practitioner in the same neighborhood where my parents as refugees, immigrants grew up in Northeast Philadelphia. I'm sure those of you that, in New York, you know where the ethnic enclaves are. So you can imagine how grateful I was to go back to my childhood neighborhood. The health clinic is across the street from the library where I discovered nursing, by the way. But most of the women in this clinic were immigrants. It's the largest group of immigrants seeking prenatal care in the city of Philadelphia. And I was caring for many Black women coming from countries that were predominantly Black. And of course, I was really worried as a nurse, not so much as a researcher, but are they at the same risk for worse outcomes as we now, at that point, we had pretty good research to show us that US-born Black mothers were at increased risk for preterm birth. And I thought, well, are they at the same risk? As a nurse, I wanted to know, because if they were, then I better make sure that we have right supports in place, because if we think about immigrants, they're socially dislocated from their social supports predominantly, mostly, but that's a whole different subject. But theoretically, would they have the same risk if they didn't have the same history of not being exposed to slavery and racism that underlies the observed health disparities in America? And of course, there's a complex interplay of both individual factors and contextual factors. So in this study, I was able to use a lot of different existing data, including a cohort study that I was involved with the researchers. So when I asked for foreign-born women living in the US at the same risk for adverse birth outcomes compared to their US counterparts, I was seeing a lot of women coming from Africa, where preterm birth rates and maternal mortality are higher than in the US, as well as women coming from the Caribbean, especially at that time, Haiti. There were a lot of natural disasters, and luckily women were able to relocate out of Haiti. So going to where you live matters. We also know in urban areas, the neighborhood where you live in has different environmental exposures to stress. Philadelphia, like New York, is a city of neighborhoods. And those living in the nicer neighborhoods, we documented in previous research, have better birth outcomes, lower infant mortality, lower rates of preterm birth than those living in neighborhoods that are socioeconomically disadvantaged. So I learned how to study neighborhoods using geographic information systems. And I was able to pull in lots of existing data, the existing data that, as a nurse using GIS that I could pull in. I used birth records, I used census data. I was able in Philadelphia to get a hold of crime statistics. In subsequent studies, I used some clinical health data, not in this particular study. And in other studies, again, not this particular one, the study that I'm not sharing today, we looked at home visiting. We looked at the use of home visiting across the city of Philadelphia, multiple different programs. So GIS is a multidisciplinary database software system. It's really cool if you like working with databasing and like working with data. It's a system where you can input data, you can store your data, you can process the data, and then you can spatially appoint the data and show lots of different pictures, maps of the data. There's lots of information. So when you think about mixed methods, it's almost like a mixed methods, because you have to be creative with your visual representation of the populations that you're going to display. So as I was learning GIS, this was the first map that I played with. And I truly, like, when you work with GIS, it's really playing. So what am I showing you here? I'm showing you what racial segregation looks like in the city of Philadelphia. And you can, if you go to any main big cities across the United States and we talk about racial segregation is when people say, what is structural racism? This, I would say, is structural racism. On the map on the left, this is, I linked census data. Now you can say this is old data from 2000. I see these maps every year. The city of Philadelphia and New York publishes these maps. The geography, the demographics do not change much in Philadelphia. There are some gentrified neighborhoods, but the map pretty much looks the same. So the darkest areas show the poorest neighborhoods in Philadelphia. And then in this, I overlaid, each dot represented 100 people. So I overlaid where the Black population based on the census data lived in Philadelphia. This actually was from 2000 census data. Again, it hasn't changed much. I can direct you to the Philadelphia Department of Health and you can look at their maps and they're pretty similar. But anyway, so racial segregation, why is it that disproportionately the Black populations live in the poorest neighborhoods predominantly? That, my friends, is structural racism. And you know, if you're not sure what that means, we can talk afterwards, but I'm not an expert. But that is, as a nurse, that tells us a lot. Anyway, in this study, I looked at individual comparisons between the foreign-born and the US-born Black women in this cohort study. It was a cohort study of low-income women, childbirth outcomes. They followed the women for 2 years. And I looked at different variables, and clearly, I'm not going to go through each one, but clearly based on sociodemographic, even to the physiological clinical data on BV, bacterial vaginosis, there seems to be a foreign-born healthy effect, a protective effect. With this population, there were 142 foreign-born Black women compared to 1,000 of the all of them were low income in this individual level. So there seems to be some type of protective effect. Okay, so now I'm looking at the neighborhood levels, and now I'm conceptualizing neighborhood exposure to environmental stress. Okay, so remember before the social epidemiologists create these scores of neighborhood deprivation. So in this study, I wanted to understand, what does that really look like? And what does it look like to the neighborhoods? Now, I'm a Philly-born, educated, raised girl, so I know the neighborhoods like the palm of my hand. I'm sure those of you who grew up in cities, you also know the neighborhoods. So the poorest neighborhoods are the darkest. Okay, so Nancy Krieger, who's a very famous social epidemiologist from Harvard, I see Ronnie smiling. She says that poverty is a good proxy for your environmental stress to deprivation. So even though in the previous slides I showed you there was lots of fancy deprivation scores, poverty is probably the most important variable to look at when you're looking at neighborhoods. I wanted to see environmental stress not just due to poverty, but violence. We know the literature is pretty clear that, you know, violence is not healthy. Duh. Some of this is not rocket science, but anyway, what does that look like? So I was able to get hold of crime statistics from the Philadelphia Police Department, and through one of the girls that grew up on my street worked in the Philadelphia Police Department as a civilian, and so she connected me to the crime analyst. And after I played with the data, you know, there were like maybe, I don't know, 50 different variables, and I had to explain to myself what would be the most significant variable living in an environment, a dangerous environment. And the statistic that I thought would be assaults with gun. There were, you know, I could have chosen homicides, but homicides is a rare event. And then there was another variable, assaults, but without guns. But if you're in an unsafe neighborhood, you have to protect yourself. You're most likely to have a gun. So I looked at assaults with guns. And, you know, as a nurse, we know if there's stress outside, sometimes, you know, if there's a stressful, how many of you had a stressful day with, you know, at work, and then you come home and you just have no patience for everybody home. You take it out on those at home. So I thought domestic assaults was also important, looking at violence outside the home as well as inside. When I asked the crime analyst at the city, they said, yeah, assaults with guns is the most important variable that we look at, but we don't pay any attention to domestic assaults. And there's also a large body of literature that says how come there's bias with a lot of these data. You remember, these are crude statistics. Unlike the fine knowledge from the best qualitative researchers that really go deep and broad, this is really just scratching the surface. Anyway, you can see there's no question what you see in this map. The patterns of poverty overlay domestic assaults, overlay assaults with guns. So then I want to look at the nativity density amongst the Black residents in Philadelphia. So again, I did a map showing where the neighborhoods that were predominantly Black. And I want to see, are the foreign-born mothers, are the foreign-born population, are they living in the same neighborhoods? If you look at, if you remember this other map, the neighborhoods, unfortunately, where most of the Black population in Philadelphia live, are those neighborhoods that have the most exposure to environmental stress. When we look at the density of the foreign-born Black population, we see that not all the foreign-born Black population live in the same neighborhood enclaves as the majority of the Blacks. And when I mapped out, I had over 60,000 birth records that I geocoded and I showed on the maps. When I mapped that out, the density of the foreign-born Black births, you see that there are a spattering of the births outside the enclaves where most of the Black population lives. And then I looked at the preterm birth rates by race and nativity. And again, this shows us our racial segregation. The preterm births to white mothers are in neighborhoods that are different than the preterm births to Black mothers. And then when I looked at the preterm births to foreign-born Black mothers, they were all over the city. So the key findings of this study showed me that in Philadelphia, perhaps there is an epidemiology paradox, meaning that even if you come from a country that has worse health and health outcomes, and you come to the United States, your outcomes might be better than the native population with that ancestry. We see that in the Mexican epidemiology paradox. And so that's what I sort of saw in this, from my results. But what I also saw that living in a toxic neighborhood overrides that possible foreign-born protection. There were clear visual patterns of good to bad neighborhoods that emerged, and the neighborhood differences were associated with higher preterm birth rates for foreign-born and US-born Black mothers. So again, I apologize for using this term, in the worst neighborhoods, there was no difference in preterm birth rates between foreign-born and US-born Black women. So that has clear implications for where resources for caring for the most at-risk mothers for preterm birth should be. Where you live matters. If you're living in stressed environments, the data is pretty clear that you're more at risk for having adverse health outcomes. So what are the nursing implications? Well, the nursing implications are neighborhoods are important to understand. Now, we clearly know that as nurses. We're taught that there's 4 mega concepts in nursing, and environment is one of them. So how do we really study and understand the environment? Neighborhoods in urban areas are important to understand because there's different patterns of health, culture, access to resources. Ethnic enclaves is a tremendous source of social capital for the ethnicities in the neighborhoods. So we have to remember that that's really important. And as nurses, we need to embrace that, amplify the social capital of all neighborhoods. How do nurses and public health serve these different neighborhoods? Well, we need to understand the data at the neighborhood level. And then we can tailor programs for the people, with the people. After 2014, I know, I'm not sure if you can see the full slide, if there's some things with your Zoom toolbars, but after 2014, I had to redesign this program of research with the rhetoric that I was starting to hear and the country was starting to hear. It was no longer safe to study immigrant women receiving prenatal care for free at our city health clinics. We are a sanctuary city, and we surely know what happened just a couple years ago. Retributions to sanctuary cities broke my heart because I thought that there's important nursing work to be advanced. The last time I actually addressed this population as such, so for me, this would now be unethical to map out where the foreign-born population lived. The last time I presented this work, besides today, was at the American Public Health Association. I had a mixed methods study. I took my research and with my translational perinatal health disparities research group, we had lots of questions. And I presented that finding: the safe or unsafe motherhood, the invisibility of foreign-born Black mothers in Philadelphia. It was the last time I addressed the population as such because it was unsafe for them. I had put in a grant to see if that possible foreign-born protective effect would persist after childbirth into the postpartum year. But luckily it wasn't funded, and I made a commitment to myself I would never address this population in research going forward. So I need new approaches to frame relevant research questions for our population most at risk. So I published the next study. Dr. Gardner was a co-author on this. What do these maps mean? What do these data tell us? And learning from Dr. Gardner, I learned more about critical theory. So in this study, we used critical theory and GIS to deconstruct one of the biggest barriers, one of the most commonly documented barriers to access in prenatal care, which is traveling to prenatal care. So we used the maps, and we were creative in how we could tell the story. The study objective was deconstruct the simple task of traveling to prenatal care using public transportation. And this was a way that we could address social determinants contributing to the observed health disparities related to preterm birth among women living in neighborhoods that were disproportionately burdened with higher rates of preterm birth compared to other neighborhoods. And this was a way that we could translate some of this health disparities research into meaningful implications to those of us at the point of care. So we used a method that we coined ground truthing the data of the data-driven GIS maps. And essentially, it was a mixed methods GIS approach. We created case vignette, a typical case to address this phenomena. I won't go through it because that would take me to 11 hours of this presentation, but the credibility, and I'm sure if we talk about what would the typical case be, it would be a mother that you all have taken care of. And the credibility of this case was verified by an expert panel of both faculty as well as practicing maternal child health nurses. And this case vignette represented a woman that had the highest risk of having another preterm birth. Women, the most salient risk factor for having a preterm birth baby is having had one before. So we created this vignette, and we identified where this mother might live in one of the neighborhoods that has the highest preterm birth rates. The neighborhoods, the census tracts that are colored in the darkest green, the rate of preterm birth was anywhere from 25 to 33%. Can you imagine? You know, when we look at cities and we say the preterm birth rate is maybe 13%, I think it was 13% at this time, but in some neighborhoods, the preterm birth rate was as high as 33%. Think about the normalization of having a preterm birth. If 1 out of every 3 births are born too early, the mothers may not be so worried as we are as nurses when we're worried about the risk for preterm birth. Well, so in the case vignette lived right here at the edge of the city in one of the neighborhoods that had a high preterm birth rate. And in order to access prenatal care, these were all the places she needed to travel to. And actually the radius is only 4 miles, so it's really not that much. It wasn't that far, you know, compared to if you were doing a time, calculating travel cost and time in a rural area. So, you know, through GIS, we were able to do lots of fun, fancy tricks. And for this one, I had a trained GIS geographer who was amazing. And, you know, someone passionate about social justice. Anyway, so we had to calculate the time and the cost of the mother's travel to the different places that she would go to. Just think about that first prenatal care visit. And for women seeking care, free prenatal care at our community health center, the woman would have to go to the community health center for her first prenatal visit. She would get the WIC forms signed. She could then go to WIC. And I'm assuming you all know what WIC is. Nowadays, for your first prenatal visit, you have your initial testing, ultrasound. So for that, the woman would need to travel to the antepartum testing center. And also she would qualify for public assistance to help support herself and her family. So our case vignette was not a low risk normal pregnancy. She was high risk. But if she were a normal risk pregnancy, in addition to the time it would take waiting for the bus, in addition to the time it would take once she gets to where she has to go, wait till she's seen or called to seen, we just calculated the time spent traveling on the buses because we could do that with GIS. So if it was a normal pregnancy, during the pregnancy, it would require 21 visits and then 16 hours. Remember, this is 4 miles. These are buses, 4 miles. And in this case vignette, she was taken along with her 2 little kids. In our case vignette, that mom, because she was high risk, required 32 visits to all the places she needed to go, requiring 25 hours of just bus time. And to her personal costs at that time, we calculated based on the SEPTA tokens, which have now changed entirely. It was an extra $100. It probably is more now. So the conclusions of that study, numbers matter. Maps can be powerful. Like I keep on saying, where mothers live matters. There's disparities. But the most important question is nurses and researchers, what do we really do about it? Because these mothers, we expect them to do more than we have to do for our PhD and what we do. Mothers who have to navigate all the services, all the domains of living in neighborhoods burdened with poverty and crime and depending on public transportation. We just looked at prenatal care as part of the healthcare, not the healthcare for her, anyone else she cares for, whether it's her children or relatives or friends, but she also has to navigate housing, navigate a lot of times legal issues, courts, navigate getting food, education systems, childcare, and social support and relationships. So as a health disparities researcher, as I continued to study more about health disparities and racism, I learned that this is nothing new. Where poverty prevails, and those who live mostly in poverty, they're divided by race and ethnicity. I traveled to other countries. I'm not going to share some of my global work, but because our outcomes in the United States are worse than all other countries of comparable wealth, I studied to other countries to see what they're doing. And what I've learned talking and sharing with nurses, maternal child health nurses, in most countries where there's poverty and those who live in poverty, they suffer also from racism and poor outcomes. I also delved into some historical analysis of our country and looking at racism and racial disparities. And actually, when I read this book, I was pretty scared and shocked. When I read, it was Mike Udell's book on a historical analysis of racism and health. 1920, the National Research Council's top priority was racial health disparities. I was shocked to learn that because as a young, well, not as a new researcher in the 2000s, I thought the focus on racial disparities was new. Healthy People 2000, we had 2 national goals. One was to eliminate racial disparities. We didn't do that in 2000. 2010, they sort of fudged it a little and said, let's reduce the racial and ethnic disparities. But this was not a new focus for research in this country, I learned. In 1920, the comparable of the NIH had a major goal to look at the racial and health disparities. That was 1920s. By 1930, the changing political scene, Germany perfected a tool of eugenics. We saw concentration camps. Get rid of let's try to create the perfect Aryan race. Well, you can imagine how freaked out I was when I read this, because what we've just lived through, a country where there's no question racism exists. So based on my research and research a country that was looking at racial disparities in the early 2000s, racism and health inequities persist in our country for sure. We all know that finally there's been a social awakening, as I said earlier, but also around the world. I am not going to talk about racism because it wouldn't do it justice to talk about it in 10 hours, in 10 weeks. And I'm not the expert to speak about it, but we can't ignore it. My colleagues, the Black feminist scholars, are really advancing this area of research. And one of my colleagues, who's a fine social epidemiologist, has shared this slide with me. And I think that this is a really important slide. As I looked at nativity, foreign-born versus US-born, what Jamie looks at is colorism, which is a term I never knew about. I have a small research group that we thought we would address a parenting program that was developed by some key stakeholders in our community. And we were going to revise the parenting program that addressed intersectionality and racial trauma in the parenting program. And Dr. Slaughters, AC, is one of my colleagues, and she studies colorism. But what this slide shows, the important line to look at here is the differential between Black and white infant mortality from 1960 on the far left to 2015. So infant mortality over time has decreased for all in this country, but the difference between white babies and Black babies have not. You can see from this line on the top, the gold line, that the differential was lowest in the 1970s. So I would partly explain that this is when we developed the NICUs and the field of high-risk maternal fetal medicine that did great benefit to decreasing not only infant and maternal mortality in our country, but also the differential. My dear friend Jamie explains this. This is when the civil rights movement was addressing racism. So if you look at this, line, I hope I'm not making you dizzy with my pointer, but look at with Obamacare, we see another dip. We see that, we made some great strides and people forgot, and the relative difference increased. Well, once Obama came into office and addressed this with Obamacare, we saw another dip. And then after Obamacare, you can imagine where this line has gone in recent times. Hopefully we'll start to see this line go down as I believe there's some important legislation addressing the disparities in maternal infant health outcomes in this country. Okay, so who's benefiting from all this health disparities research? That's where my moral distress comes in. By I think it was by 2011, first of all, I had this fun data science training, and some of the work that I was exposed to, I realized that many others weren't. So I created this translational perinatal health disparities group. And over the years, I've had public health students, nursing faculty was my way of disseminating what I learned to others, to sensitize, to broaden the scientific capacity amongst nurses and others who are really dedicated to this work. But in practice, nothing was changing. And in fact, at the health center where I was practicing as a nurse practitioner, we went to electronic health records. Nobody asked us at the point of care how that should be implemented. And what was happening for me, it became even unsafe to practice because the implementation at this particular center is a little complicated because we were contracted from one of the academic health centers in the health department. But I was starting to see women who maybe hadn't come for prenatal care for 6 months and their lab work was never checked. It was just a system problem. So I realized I couldn't complain about it unless I went to the health department and says, use me. We know all this research. How can I help? How can you use me to try to make the systems better? At the same time, I was contacted by a nursing director of a perinatal home visiting agency. She said, "You're a nurse, you do research. Can you help us? Our nurses who are doing home visits, we're seeing women that are sicker and sicker. We have so much data. Can you help us analyze our data to make sure that we're guided by the best practices, the best evidence-based practices?" That model of home visiting was actually, those of you may remember Dottie Bruton's transitional care model. It started with maternal child health population. Yay, Ronnie, I want to kiss you, but you're lucky that you're on the computer because you can understand my colleagues, my nursing faculty friends. We were shocked. Here we are, nurses practicing in the hospital, teaching the women's health course. Some of my colleagues were working in the hospital. Some were like me, working as nurse practitioners in the community. We had no clue that this modified transitional care model for perinatal home visiting still existed. It's not included on any of the evidence-based models for the Affordable Care Act. It's not in our nursing textbooks that we teach undergraduate and graduate students of women's health. Our questions, so they had questions of us and we had questions of them. How prevalent are these nursing services? So the first question that evolved was, what is the utilization processes and outcomes of this model perinatal home visiting services? So this study, it was a secondary analysis of existing data. The first phase, we used administrative logs. Being a nurse and having nurse collaborators in the community, my public health researchers, they usually have to pay so much money to get the data and to get people to use data. I wasn't going to waste anybody's money. This was a teaching opportunity. So anyway, the community-based organization is called Stork Watch, and sad to say, when I say my moral distress, they couldn't stay in business. They actually had to stop the service after 30 years in recent years. But anyway, they serve the greater Philadelphia area. It's an independent agency. It wasn't connected to any hospital. It wasn't connected to any federally qualified health center or any governmental agency. They received referrals from obstetrical providers when they were taking care of high-risk women that needed extra intensive nursing care because of their medical problem. So the key findings from this study, and I'm really squishing this up, we're still analyzing data. In the first phase, we looked at the number of authorized visits on that first referral. And we saw that it varied based on the insurance company. The mean number of visits that were authorized were at that first visit was 4 visits. But those who had hypertension, diabetes from the get-go had more authorized visits. But it really varied. And if the women had Medicaid insurance, the number of authorizations was greater than if she had private insurance. So as nurses, as advocates, just because you have private insurance, it doesn't mean that your access to healthcare services that you need are going to be better. Phase 2, what we were able to do is we were so excited to learn more. And the director of the agency said, well, Joan, we have all the health records. Why don't we create a research database? And then we can actually look at the characteristics of the women. We can look at the outcomes. I said, why not? And I actually wanted an excuse to learn how to use REDCap. And so I drove up after getting IRB approval. I drove my car and in my trunk went all the records. And then it took a long time. I actually wanted to use this. I used most of my studies was based on existing data. So this gave me an opportunity to abstract the clinical records into a research database. Even though there were 239 women that we were looking at that received home visits for diabetes, it encompassed thousands of home visits. And we were able to digitalize all those visits into a research database. And we have 3 articles under review right now, and we have published a couple. But one of the first thing that really shocked me was the mean weight of the patients that were being visited by the home nurse, the obesity. The mean weight was 240 pounds at that first visit. And the range was up to 472. my son got IRB approval. One of my children helped me during the summertime with this study. And I was for sure, this son especially, he's fast, he's sloppy. I was for sure that, he made errors, but I pulled all the records. I mean, the women were weighing a lot. One that I doubted my son's sloppiness, that woman started out 354 pounds. So, are we preparing our students to go and do home care with large populations? And you can imagine the comorbidities. And we presented at different conferences some of the comorbidities. So diabetes and hypertension weren't alone. These are complex patients. The concerns from the nursing notes were the poor adherence to the diabetes self-management needs. And from a research perspective, how do we measure this intensive perinatal nursing care in the home? How we can create a longitudinal measure for glycemic control. So we're working on that now. But that's an important area to look at, because the glycemic control after all these visits is an important nursing process outcome. So the implications for nursing research, and in my travels and perhaps yours too, diabetes during pregnancy is a global epidemic, global health problem, and it's an important area to push nursing research. Diabetes during pregnancy threatens maternal and infant health outcomes and life course health trajectories locally and globally. Diabetes self-management is required, and there's, I'm sure you, like I, have no faculty across the globe that are doing research in this area. We need to make sure we have good outcome measures to capture what nurses are doing. And pregnancy is a unique window of opportunity to change life course trajectories for those with and those who are at risk for diabetes. Hyperglycemia during pregnancy is toxic both to mom and the fetus. And what are the best practices? So health inequities and maternal mortality. Unlike preterm birth, where there are true gaps in our knowledge, in the biology of what makes some babies more likely to have brain injury, with maternal mortality, the data that we have read about in the New York Times, the data that we listen to on the news, it's different. We know how to prevent maternal mortality. When I was a labor and delivery nurse back in the end of the 1970s, I never saw a mother die in the hospital. That's very different than what labor and delivery nurses, the stories we hear today. And it is indeed, I believe, an effect of system failures as well as the health inequities that we live in. So I'm just going to share, so my work with the Philadelphia Health Department, when I went to the director of the maternal, child and family department, I said, use me. I have all this research training and we need to, I want to see us have better outcomes. Philadelphia has the highest rate of maternal mortality and infant mortality of all the large cities in the United States. So she asked me if I would co-lead the Access to Care group. And through this work, I was, knowing the public health, knowing the nursing, knowing health informatics, I was able to talk about what would it be like if we could use technology to have at least a central intake system, at least for home visiting. We were hearing from everybody in the field, from stakeholders that were either referring to or working in home visiting, from even our community leaders. There's so many things that are available. When people call our mothers are confused. What home visiting agency are you working for? So we decided that our agenda, the common agenda for the Access to Care group, would be develop a central intake system for home visiting. It was a very complicated endeavor. It took 5 years. It's going live now during COVID. But it was very complex legally because all the different community-based organizations had to agree upon sharing their data. So reflecting my community and public health engagement work, another disappointment is, at least in the Philadelphia area, and every community is different. I look around when I would go to these meetings, I was either the only nurse in the room or I was the youngest nurse in the room. And I've been a nurse for 43 years. That was very, very different than in the 1980s when we were developing the pediatric nurse practitioner role, we were developing the women's health nurse practitioner role. I was then amongst a nice, healthy crowd of nurses and physicians and public health practitioners and social workers and nutritionists. I was the youngest then, but there were many other nurses. And what I'm finding also in my work recently, many of our public health research colleagues, physicians, public health researchers, have never worked with maternal child health nurse researchers. And as I got involved in ATMATCH, which is a public health, ATMATCH is the Association for Teachers of Maternal Child Health. It's sponsored by HRSA. And they were thrilled that there was a nurse faculty that was joining them, and I actually co-led the workforce development. But through this work, I learned that HRSA had defunded our maternal child health nurse training. So in part, maybe we can push to have that reinstated, because as we see in our country with maternal and infant mortality, nurses are still the largest workforce caring for our mothers and our children. So this has critical implications for us in academia for developing the next generation of maternal child health clinical nurse scientists. There's a real need. So some conclusions, and this is a big discussion. When we talk about racism, we talk about health disparities, who should tackle this from the research perspectives? Who should, as white faculty, are we building our academic careers exploiting this phenomenon? Is this time for our colleagues, our Black sisters, our scholars to lead this research? I sometimes get very sick to my stomach when in academia, it's not about what you do, but what you're leading. It's me and I rather than us and we. Anyway, that aside, cardiovascular disease is the leading cause of maternal death and morbidity in the United States that needs to be addressed. Many women during childbearing are affected with diabetes and hypertension. And our medical offices going to prenatal care does not give women ample time, does not give the clinicians, the doctors, the nurses ample time to really make sure that we even listen to our patients. Those who conduct home visits have much more time. And so as we look at the models of home visits, are the previously evidence-based practice that's being scaled up with public health monies, are they the right models? Where's nursing in them? So I'm at the end. And my concluding key points is that reproductive health inequities is a human rights issue for women and their children in the United States and the world. It is egregious that the wealthiest country in the developed world has the highest rate of maternal and infant mortality. Research can, and it must be translated into action. And as I said before, there's a need for maternal child health, clinical and translational nurse scientists. And as I wrestle with my own moral distress as a health disparities research, I am so proud to be a nurse. And I must not exploit the community for my academic research. And my mother's words still echo strongly in my mind: be smart, be nice. It's a tough world right now, everything that we're living, and try to help whoever you can. So I thank you.
Oh my gosh, join me. Unmute yourself so you get a round of applause. Everybody, you can see everybody, Joan, for sure. And I'll start by saying that I would have 10 hours more questions, because you just excited me in so many ways. There's so much depth to things you said. And so each of those points warrant another session. But what I'm going to do is I'm going to ask Dr. Gardner to kind of add some collaboration parts to this, because it's one of the things that I invite my doctoral students. You've obviously exemplified how you work with non-nurses and mathematicians, data scientists, we know what that is. But I'm going to ask Marcia if you'll lead a little bit with some collaboration stuff, and then we'll open it up.
Yeah, well, first of all, it's a privilege to have Joan join us here. I have known her for a very long time, since I was a doctoral student at Penn. And I'll just say on a personal note that I coincidentally met Joan in the lounge, and we just started having a conversation about our shared areas of interest. My, I guess, lens on everything is, caregiving and developmentally vulnerable young infants and children. That's kind of where I've always been in my work, and I certainly don't have the program of research that Joan does, but I think Joan and I have come in and out of working some together, because of our shared overlapping interest in mothering and strengthening the family. That's really where a lot of this started. But I would say in terms of collaboration that Joan has invited me in to her work. And I don't want to speak for Joan, and you can jump in, but because where the research was leading her in these individual cases, there was an overlap in terms of my own, I guess, background or interest or expertise. And I think that's really that's where the collaboration has emerged from, is you need multiple lenses. And I mean, Joan, you have all of those different lenses in your work because of your collaborations with a lot of others. But you need multiple lenses in your work. You need to have people speak from their own, I guess, base of expertise and their view, of the literature, of the environment, and also, kind of coming from their own clinical context. And so I think that's, that's where our collaborations really started. What is the overlap you have with your, the members of your research team, and where do you differ? And we've done some other, we've done some work on developmental vulnerability, on developmental disabilities, bringing, moving in and out with different, with different people. So, and I'll just say, as Joan has mentioned many times, that a lot of her work has been learning something new. And so that little GIS study that you shared, I was very privileged to be part of that, but that was also about learning something very different, because I certainly didn't come into that with any knowledge about GIS, but I sure came out of it with quite a bit. So, I mean, I hope that sort of addresses a little bit about what you're talking about. I think you've highlighted a lot of really critical questions, particularly for me, the question of how do we use this, your program of research, the way it's evolved, how do we use that in understanding how to help our students develop a program of research, find their, the theme that they're going to orbit around, but also, as you pointed out, I think multiple times, what do we do with this now? We have a relatively immovable healthcare system in a lot of ways. What do we do with it? Because finding out, I mean, we've all been guilty. A lot of us are very guilty, right, of descriptive work that explains and, promotes our understanding, but we get stuck there. And I think that for all of us, that's the challenge, I think, is not getting stuck in, the knowing part, but, moving it into some kind of substantial action that will make the difference. And so.
Thank you. That's exactly it. And the other part that you also did, Joan, is connecting that to policy, and our PhD program has an emphasis in policy. You made a couple of key points I can't wait to bring back, because our policy students seem to think that they have to find some wonderful political point of view, and they just need to lobby to get maternal child health services back. When they closed Bureau of Maternal Child Health Services, we knew that we were going to lose the kind of data that and support. So addressing all of those things, Joan, I thank you, but I'm going to ask folks to ask wherever their burning questions might be. So unmute yourself and just see if you can call out without making it too messy.
Hi. Okay.
Nikki.
All right. I think I could be quick. To follow up on what you're saying, Ronnie, you hit the nail on what I wanted to ask. One of my many hats that I wear is that I'm on the AONL advocacy committee, And one of the things that we're advocating for is Title VIII funding. And my question is, you mentioned that HRSA funding has been defunct for maternal child health nursing. So I'd like to hear more about that and how I may be able to advocate for this program.
So the University of Alabama runs the public health at-match program. HRSA has a lot of funding for maternal child public health. I don't know much about the maternal child health nursing training programs, because what I learned is that the woman who used to lead them, the nursing faculty at University of Alabama, she informed me that she used to lead them, but it was defunded. So what I think is important, if you're in this position, to do some historical work to see what it was and to bring it back. You know, we went through a recent era where women's health, maternal child health has gotten very little attention. You know, for nursing faculty, and even for, actually, I should step back a little, even for public health researchers that had areas of, you know, that this is their area that they love, or their area of research. You know, nursing researchers are different than public health researchers. Public health in the United States is not a practice discipline, it's a research discipline. And I actually am going to say something very tragic. One of the women in the Philadelphia area that has served this population for decades, she trained at University of Pittsburgh under one of the leading public health by our microbiologists in bacterial vaginosis, linking BV to HIV. Woman Deb Nelson, I say her name in honor of her memory. She had several R01s. Because funding got so bad, she was the major breadwinner of her family. She was sort of like disregarded as unimportant because she wasn't bringing in any more R01s. She actually committed suicide. So I say that because in academia, sometimes we make people feel less than because of research dollars they bring in. If you're, you know, in this population, this maternal child, you know, think about the last political administration. What was the most funded? Aging. Not that that's not important. And I know I was blessed to be with both of my parents and taking care of them because of a lot of research in aging. But my population may not live that long. You know, so I think it's really important that we start, you know, in a lot of the work, and I'm really proud of a lot of the scholars that are leading this work, a lot of doctors, women of color, and my public health students that work with me on my data, 4 of them are now in medical schools. I'm really proud of that. But nursing still remains invisible in this area. And we really need to make sure, just like the media is making sure that we know that nurses are at the front lines of caring for COVID patients. And through a project I'm working on now too, nurses are at the front line leading COVID research in a lot of the CTSA centers. But we need to make sure that our policymakers understand that nurses are still at the front lines taking care of our mothers in the hospital, our children in the hospital, our children in the community, our mothers in the community. So did that answer your question?
That speaks volumes,
Yes,
Nikki.
thank you.
That speaks volumes because it's the invisibility that we need to, and you even just rattled that cage in your work. But specifically, is that Ann Turner Henson from Alabama? From University of Alabama?
No, I wish I got to work very briefly with her before she fully retired, but it wasn't her. But I'm sure she, I mean.
Yeah, I'll try and track it down if I can find it for you, Nikki. That way I consider myself the making connections. And I have some other students on this call that I've been trying to lead to make connections with other people. Yes, Sharon, you and other people that we've been trying to motivate, because, you know, I like building teams. Sometimes they don't know that they have a team partner on the other side of the screen. So I'll look into that for you, Nikki. Anybody else?
Thank you.
Questions?
Well, I just wanted to say thank you, Dr. Block. That's probably the only man in the room. And this isn't even a room, but my own connection with, you know, maternal child health was back in 1977 when, as a nursing student, I tried to get through it as quickly as possible. But you raised some really, really great research points, and it really is something that should be prioritized. Poor people are poor in every way. They're poor in resources, they're poor in diet, they're poor in access. It's it's almost as if this is a moving target. You said earlier how inroads were made in the late 1960s, early 1970s, when the civil rights movement had peaked, and there had been some initiatives also under the Obama administration. So I'm kind of wondering, how do we bring how do we bring this problem forward to the public domain so that things can be addressed? Because this is a very serious issue. And one other question I just had, and it's just an opinion question, or maybe can tell me, why is it that at 4 hours after birth that infants, neonates, are subjected to brain injury? How does that make sense? I mean, what would happen to cause something like that?
So that's actually a good question. And when I proposed to look at that outcome measure, I had some pushback. And so there's always this battle. When does brain injury that causes CP occur? Is it from a traumatic labor, or is it a hypoxic insult that occurs before labor even starts? And the current science says that if there's hypoxia, even before labor begins, as early as 4 hours after birth, you might see signs of it. So what type of hypoxia? So we know inflammation. Now this is similar. I'm not an immunologist, and I wish I had the patience and time to better understand this. But the immune system responds to infection. So if a mother has a periodontal disease, we know the literature with bacterial vaginosis, certain strains of bacteria can cause an inflammatory response to the infection insult. It's the inflammatory response that causes that at the cellular level, the hypoxia. Oh, there's my dog, sorry. Maybe my dog can explain it better. So the science, so it's similar to that inflammatory response, like the cytokines. Oh, dazzle. So if the immune system is weakened, so like a UTI, all the different viruses, and of course there's COVID is now it can be very dangerous. So it's that response, the immune, the susceptibility to infection and having an inflammatory response. The cytokines creates like a chemical toxicity to the in utero environment and can cause in fetal brain injury. Does that
makes sense?
That's an excellent answer.
sense.
I think it's a truism, if it's not proven medically yet, that almost all diseases have their root in inflammation. And yeah, when I think of Black communities, in just a simplistic way, I think about the diet. And I think if you have opportunity to go back to those neighborhoods, I'm sure that every other corner will have a Kentucky Fried Chicken or a McDonald's or some sort of fast food place. That's not good food. It's bad food. In fact, I'll close with this. The other night, we were running out of dog food, and my wife stopped off to get some, and the dog food was $4 a can. I told her, don't bother getting the dog food. Just go to McDonald's and get a Happy Meal, and we'll give that to the dog because it's actually cheaper. But nutrition, poor food, poor resources, poor access to healthcare, that is part of what upsets me so much, and the lack of resources with mental health. I don't know what's happening, but it's like a moving target, healthcare. And I think as nurses, we should be on the forefront, and we should try to address problems.
Thank you.
I'll stop there. Thank you.
Thanks, Mike. You always bring an interesting perspective too. I know that, and I won't call on people, but I know one of our colleagues does health disparities or inequities in other populations. So perhaps she'll speak up.
Yes, I would like to ask some questions and also make comments. I do study health disparity among Asian immigrants instead of, to me, I just feel for the problem among Asian immigrants and Asian population really lack of data because so not when they've been grouped into this other, they basically disappear from the
Right.
from the data from everywhere. So my passion really is to explore, to dig them out and then study them. And interestingly, my very first public paper published was actually on healthy migrant effect on their smoking behavior. So based on my research, I find really years of migration that actually reduce that protective effect. So I would like to ask you, do you see that happen? Especially, I think one thing interesting you mentioned is for maternity, child caring, all this domain, you can actually use the number of children, right? The first birth, a second, and a third, and to see the differences. So from that perspective, do you actually find the data showing that that protective effect decreased as the number, the following childbirths? And also for the latest study you talk about the home visit one, you have 260 some cases there in your database. Do you also see difference in terms of nativity of their health condition?
So I'm going to start with the last question first because I may not remember that first one. In that study, so what was so much fun about that last study is I used clinical nursing records, and the nurse, director of the nursing agency, was trained as a nurse as I was during the period of time when we talked about color blindness as being a good thing. Now we know now in the more recent discussions, color blindness is a way to just, is not a good thing. But when I was raised as a nurse, we wanted to treat each person humanely, not stigmatized based on their ethnic background, whatever. So in the records, they didn't have that. When you work with secondary analysis of existing records, you can only analyze the data that you have. So race and ethnicity is not even in that data set. In terms of the healthy immigrant effect, there's a lot of fascinating, academically interesting research on that. I stopped that line, or stopped addressing it back in 2014. What was interesting to me as a nurse is that when I looked at the different places where the foreign-born women were coming from, they were coming from so many different countries. So when you look at a woman who's escaping Haiti after an earthquake coming to Philadelphia versus a very highly educated woman coming from Senegal who's an attorney who's coming to Philadelphia, it's just too many differences between the foreign-born women to really study the healthy immigrant effect compared to the epidemiology literature looking at the Mexican population. The epidemiology paradox stems from research in Southwestern United States that looked at with duration, with tenure of living in America, that the American life coming from a country that now when you come to the United States, you're a marginalized minority, your health deteriorates. So theoretically, you would assume, just as you said, the longer you're here, that there's more deterioration in your health because of the exposure to all the yucky things, especially all the yucky things of American life. If you're poor and if you're a marginalized minority that's subject to racism, as certain ethnic groups are, certain ethnic groups are not when they come to this country, that your health deteriorates. So tenure is really important. I didn't have those variables in my initial study. In my proposed study that I was going to do for postpartum health to see if that what happens afterwards. I mean, from a sort of like anthropology question, it's interesting from an academic perspective, but my real issue was as a nurse, the postpartum care for this population, and really as a nurse postpartum, having competent, adequate care for postpartum care for all women is a huge gap in our healthcare system. Did that answer your question? I think there was some other part. But the Asian is really interesting because the CDC defines different ethnicities and we're sort of bound in that, right? So Asia, if somebody's Asian, is there a difference if you're coming from East Asia, Southeast Asia?
Yeah.
Right? Pakistan.
Dr. Block, I want you to meet Dr. Kerben. for future conversations, because inevitably, I know from Leah's work, she is a secondary data analysis of large data sets kind of expert, and I think you would enjoy having a chat with her as well on more issues, because we've teased these things out in the past. And I'm gonna shamelessly, Marcia, did you have something to say? I've got a shameless closing. My shameless closing is to comment. I usually don't, but I love your language of foreign-born Black, U.S.-born Black. We have a dissertation I'd love for you to have a peek at on what we called, and it was really hard, you know, it's very challenging with language, but we used Caribbean Black and non-Caribbean Black, as opposed to Senegal or some of the others that you obviously have more expertise in. And yes, those things were there in interesting ways with hypertension in women. So I thought, given our general interest in women's health overall, you'll hear from me too sometime. So if that's okay with you.
Absolutely.
I'm going to close. And if anybody has a burning question with 30 seconds, it would only take a 10-second. Let me introduce you to Dr. Laura Candelaria. Wave your hand, Laura. Dr. Laura Candelaria works with Diane Spatz, and I know that you know Diane. So in human milk donation and other areas. Dr. Anne-Marie Parazak, who's gone online, obviously, with a student. She's in the upper corner as well, but she's also someone that I'm so glad to make your acquaintance and get to know you. Without any further comments, we're at 1:30, 1:29 in 10 seconds. I like to close and make sure that I let people go at 1:30, but I can't thank you enough. And so if everybody will show this in the screens that she can see. Joan, I really appreciate you taking the time and coming to visit us, and sometime when we actually can be back together, and I get down to Philadelphia, we'll have some dinner and a glass of wine. Best research teams get started over a glass of wine. So thank you very much. And thank you, everyone.
Thank you.
Bye-bye.
Have a great
Thank you, Joan. Look forward to talking to you soon.
Thank you. Have a great weekend, everyone.